Well, welcome back to the channel. It's Dr. Durst. And today I have a special guest with me, and it's Greg McKettrick.
Thank you very much. I'm very happy to be here. As Dr. Durst said, I am Greg McKettrick. I'm a pharmacist and have been for over 35 years. I come from a strong compounding background, so very familiar with the ins and outs and rules and guidelines. I currently am with Revelation Pharma, which is a network of 20 compounding pharmacies all over the country. I don't actually work in the pharmacies these days. I run Men's Health, so I'm a clinical liaison. So I educate our staff, I educate patients, and I educate our physicians, do in-services and seminars, speak at a lot of conferences, those sorts of things. I'm also a medical advisor for the BHRT Training Academy, which that's bioidentical hormone replacement therapy. And what we do is we work with prescribers, train them in all different aspects, different realms as far as compounding, hormone, sexual medicine, you name it. I am very intimately working with nitric oxide. I have for a very long time, still on the advisory board with Berkeley Life, but I also work with Approved Medical Solutions. I also am now adjunct faculty with the Peptide University, which is a wonderful thing. It helps me to understand better and help to educate patients as far as the use, application, and introduction of peptides into practices, especially for clinicians. So yeah, lots of different things going on.
Lots of different things. I love it.
Pretty busy, which is how I like it.
Yes. Well, we'll dive into a few different things. There's a multitude and probably endless amounts of things you can speak about. So some of the exciting stuff that you have going on, then I know that we have a lot of male viewers. So I do want to, and they do have questions about compounding. So that was super helpful. But they also have been asking a lot. So I figured I saw this on your presentation, a lot of conditions and a lot of information for men and sexual health on your presentation. But, if you wanted to touch on, number one, some top peptides, like the top 5 peptides that you would use for male sexual health, sexual wellness, better sex, and also delayed ejaculation. Like, what would be your top, recommendations for that? Because that's a big question with our viewers.
Yeah. So now there's 2 different sides. There's premature ejaculation and delayed ejaculation. So they are kind of the flip side of a coin, because one of the things that we find, there are no FDA approved treatments for either. Just put it out there. There's no such thing. So for premature ejaculation, what do? We use medications that are known to have side effects that cause sexual dysfunction. So what's the most common thing is to prescribe patients SSRIs, which they are effective. I think Paxil, taking a 20 milligram Paxil once a day, has about the biggest impact on what's called the IELT, or intravaginal ejaculatory latency time, meaning the time from penetration until climax. It's known worldwide average duration of time of IELT, the duration that you can remain prior to climax, it's about 5.5 minutes. So premature ejaculation is fairly subjective, because if someone has very severe premature, they could be 30 seconds or under a minute, and then they would quantify mild or moderate in the 2-minute range, which for a lot of folks you're thinking, holy cow, that seems very short. But the problem is this is present in up to 70% of men. It can be, actually, they're looking now at genetic links to this. Some of it is emotional, some of it is psychological, some of it is physiological, due to nerves. We know that higher testosterone levels actually kind of condition men that it's a higher rate of premature ejaculation. So here we have guys that are having a significant problem that has a huge impact on relationships, on intimacy, on their psychological standpoint. And what's the answer? They're going to put them on a daily SSRI. Well, as a pharmacist, what's the thing you talk to when you counsel patients about? The first month that you're on that SSRI, it's basically just kind of building up in your system. So you're dealing with side effects while you're waiting for this to become effective. Here's the thing. Yeah, you can really increase latency time using Paxil, but guys won't do it. They won't stay on it because they don't want to be on something they have to take every day. They don't want to have to deal with the side effects of taking that. So how do you find something that doesn't have to be taken in that way? And so again, trying to find root cause to the problem and what's the solution. One of the things that I found was this medication. It's still in an antidepressant family, but it's called clomipramine. And clomipramine, which is an Afrinil, same thing, but clomipramine can be taken 4 hours in advance of sexual activity and will increase that intravaginal ejaculatory latency time, the IELT, by up to 5 times. So you take someone who's at 2 minutes, you take them to 10 minutes. You take someone who's 3 minutes, you take them to 15 minutes. That's substantial. Now, to even further benefit and to augment the effect of that clomipramine, I compound it with tadalafil. So you add 20 milligrams of tadalafil to that dose. That in and of itself helps with premature ejaculation. That helps with sexual function and quality of the erection. So now you have two components that are working together to really give that more beneficial outcome.
And you're talking about an oral form of that? Okay.
Yeah, because there's a lot of, you can call it behavior modifications for premature ejaculation. You can masturbate before sexual intercourse. You can use numbing creams or sprays or condoms. You can use the pinch technique or the stop and start technique, a lot of different things. But in essence, you're really putting a lot of manipulations in, which cause some discomfort. And, it's not as pleasant when you have to have this whole mechanical process in order to have intercourse, to have sex. So some of these are ways that we can actually really augment the effect. The other thing that we can do, a little bit different, but even using penile injections. And the reason for that is the duration of erection that you achieve with a properly dosed penile injection, like a trimix, bimix, that sort of thing. It tends to override the prolactin release after an orgasm. So typically, when a man has an orgasm, body releases prolactin, boom, you get sleepy, roll over, you're snoring. With a penile injection, a lot of times you maintain that erection beyond the initial climax, so you can continue. And if you think about it, if we can really improve that overall outcome and the experience, this is going to help the whole psychological factor, because once men start down this pathway, there's this huge negative feedback loop. And now you're doubting yourself, and it's anxiety, and you're worried, and you're anxious about having sex. And boom, you just have more problems that start to layer in. So if we can alleviate that and get them, sorry, this is my phrase, get them out of their head and back between their legs. That way, we're actually focused on really what the task at hand is. So, those are things that can be very beneficial for that. As far as delayed orgasm, that can be trickier because there can be nerve conduction issues. Again, it can be psychological. It could be medication induced. Obviously, if someone is taking something like an SSRI and this is the outcome, that they have anorgasmia or delayed orgasm, a lot of times it takes a little bit of real homework to find out, is there a better drug? Is there something else that can be used that has a better side effect profile? The other side, like I said, in some cases, delayed orgasm, delayed ejaculation can be related to hypogonadism, low testosterone, low sex drive, low energy, low arousal rates. Increased testosterone, you have the ability to counter that to a degree. In other cases, we'll use things like neurotransmitter, like oxytocin, the cuddle hormone, right? But by implementing oxytocin, you increase the feelings of sensitivity, sensuality, sexual satiety. It also is fundamental in erectile and ejaculatory function for both men and women on that point. Another one is apomorphine, which is a D2 dopamine agonist. Now, this actually works in the hypothalamus. It stimulates the initiation of the erectile cascade. So you're actually, from the central nervous system, generating the foundation for the erection. Now, think about taking that drug, which not only helps with the erection, but it's a dopamine agonist. So you're getting a dopamine surge. This is again mood, libido, drive, arousal. So let's take a PDE5 with oxytocin, with apomorphine. Now you have a kind of a sexual cocktail that can be used again for both men and women, but you get better blood perfusion, better engorgement, whether that be penile engorgement, clitoral engorgement, vaginal engorgement, better orgasmic function, and better arousal. So all of those play together. And this is just another way where we can kind of overcome some of these deficiencies and some of these issues.
Yeah, I see, I love that. And also critically think through it, come up with solutions, combine them.
Yep.
And when you're combining even those two products, the PD5 and apomorphine, would you do it are you usually doing it like in a sublingual or tablet form?
Well, I'll say this. So some of these this comes from, again, the science of compounding, right? You have to work with the element and what the characteristics of it are. And if you are working with particular active ingredients that are temperature sensitive, that's going to change the dosage form that you can use. So we commonly will use combinations of different PDE5s and apomorphine, and we can put those in a sublingual troche or an RDT or ODT. But when you start to incorporate peptides like oxytocin, now this is a very temperature sensitive element. Heat kills the API. And even the pressure and manipulation from tablet formation, tablet press, can do the same thing. So if we're using oxytocin, we'll typically use it as a nasal spray or a sublingual suspension. And that can be done with the PDE5 and the apomorphine, combining them together in that same product. Okay. So again, part of this is what's the application, and part of it is, all right, now where's the roadmap? How do we actually get there? Where's the Betty Crocker cookbook that we use to actually put these things together?
Okay.
And you mentioned peptide, which, great peptide for both men and women for sexual function is bremelanotide, or PT141. The commercial product is Vyleesi, which is an injectable for women for hyposexual desire disorder, so low libido. And it is effective for a lot of people. For a lot of people, it causes a lot of nausea and side effects, but it works for both men and women. And sometimes the effects that we see in men are much more profound than they are in women, to the effect that they call it second puberty when they're using it, because it's just that exaggerated of a response. So that is a great example of a peptide that can be used for sexual function. And then there's another one called melanotan 2, which is related. Again, they're both in that melanotan family, so you do get this kind of natural dopamine surge. The negative to those things is that they are so effective that you're really limited in how frequently you can use them, because they're basically burning through the dopamine in the system. They're causing this mass release, which is causing the surge of effect, great desire, great erectile and sexual response, men and women. But if you do it more than a couple of times a week, you're not going to get an effect from it, because your dopamine reserves are just depleted. So you have to combat certain things like the side effects and then the application of it. So having other compounds that aren't in that same limited status, more frequently, they can be coupled, they can be paired. Maybe the weekend gets the PT141, and during the week you're using the vardenafil, oxytocin, apomorphine. Just different ways of going about it. There's other peptides that are also great. Even like the growth hormone analogs, the testosterone and ipamorelins, they drive up hormone levels. They've shown that even like the BPC 157, which is most commonly used for body healing, is the body protection complex. So soft tissue injuries, damage to the body, anything like that, that actually has a healing effect, because there's actually some remapping in terms of blood vessels and different things that can occur. So, there's a plethora of ways of going about this, and
Mhm.
it's really, how do you know what to do, and
Mhm.
what is the best fit for any particular individual. So a lot of the peptides that are out there, you can go to these sites that they're just internet sites, and Joe Random can go out there and purchase whatever they want, but you're not going to have any dosage. You're not going to have any guidelines how to use it, even how to mix it. So some of that is really risky. And, hopefully, we're seeing some push from Kennedy Jr. and with, against the
Mhm.
trying to get some of this stuff approved. So we'll see what happens with it. In the
Yeah.
meantime, we do the best we can.
Have you seen, or do you feel like there's a lot of progress there? I haven't seen, at least I haven't perceived much progress yet. Not that he's not trying, but I just haven't seen much
The,
official.
the problem is this. I was on a call with the FDA last December,
Mhm.
and in that call, they slammed the door on peptides. They literally said, we don't know where to put these. They're not tested. There's no efficacy or safety trials that have been done with this. They're not categorized in any little shoebox that we can hide them in. So
Mhm.
until that happens, no. Well, what are they saying basically is that until big pharma takes
Mhm.
this stuff and puts it through these huge clinical trials and everything, that they don't know what to do with it, so they're not going to approve it. The funny thing is, since this conversation has started, and like you said, I haven't seen a lot of progress. I haven't seen really any movement of the dial as far as getting stuff approved. But as of 2 weeks ago, there were 1,500 big pharma applications for research and development on peptides.
Yeah.
So, as soon as that switch gets flipped, you're going to see, basically this surge that's going to come out with all the studies and all the rest. So we'll see what happens on the market.
Yeah, well, I did do a deep dive multiple times into just safety issues because obviously there's lots of that, like, well, hey, we're not sure about the safety, but there's been a lot of use, just not a lot of large scale studies, obviously, but no safety concerns that I could find over and over again for these peptides.
And
So you can state safety concerns and they're injectable, obviously. That's probably the bigger concern, just getting them from, a safe FDA regulated facility
well,
than it
and
is.
again, you've got to be careful because FDA regulated is not part of that game right now, because these do not fall under the guidance or under the purview of FDA or the boards of pharmacy or the medical boards, even, because the fact these are almost categorized as supplements. So they are
Mhm.
just not under anybody's real scrutiny. You have to really know who you're dealing with. You have
Mhm.
to vet these providers. Are these coming from US based sources? Number one. Or is it being done overseas and you don't know what the heck's in that vial? Number
Mhm.
two, is the facility CGMP approved? Are they doing independent third party testing? Are they providing C of A's with every lot? So there's ways of doing this, but to get exactly to your point about the safety, and I applaud you for that, because in speaking to a whole room full of lawyers, as well as speaking to insurance providers, number one, to understand these peptides, even though they're not FDA approved, they are legal. Number two, and this is coming from the insurance side, zero claims as far as efficacy, as far as safety, as far as patient injury and harm. So there's data that is being compiled as we go through this. But again, it falls more into that anecdotal, saying, hey, we've done this with X number of thousands of patients and haven't seen anything, but it's not in, the whole peer reviewed FDA IRB trials. So it's never going to have that same documentation to it. But again, from the legal side, from the insurance side, these guys are looking at this stuff going, we're good with it.
Mhm. Yeah, it is interesting though, because again, they will state safety concerns. They've even done that with compounding pharmacies and guidelines. And it's interesting because the guidelines are by societies, and the societies have massive pharmaceutical backing of even most of their meetings. Because I've also deep dived into all the guidelines, and societies that are writing the guidelines and the experts that, aren't even practicing whatever they're doing guidelines on necessarily. But the meetings are actually, and most of the experts have some kind of pharmaceutical backing. So I think that's, if nothing else, a mixed interest and a conflict of interest for sure.
It should be
And
a huge
so,
warning flag for
yeah,
anybody who's reading what's being put out there. I mean, but look at the bottom of the note, look at the bottom, what are the affiliations, and then, do a Google dive on that author and see, what is their affiliations, where are they connected? Because a lot of
yeah.
times what you see is those letters, those statements, those guidances that are written are really coming out of, the big pharma motivation.
Yeah, well, they do have an extensive pharmaceutical backing, both the speakers and the societies, and those are guidelines written, from different medical societies. But one of them, when they came out with the guidelines, and again, don't recommend compounding pharmacies because those are almost in all of the guidelines that they don't recommend compounded versions, and safety concerns were referenced. So if you click on that link, it goes back to the 2012, where there was one intra-spinal injection of a steroid, and there were some bad outcomes. But then if you again, when I'm completely bored on a weekend and I'm deep diving into all this, it's interesting to see that obviously if there's bad players and adverse reactions on any conventional or compounding, that's the only one that they can reference. But if you look at any FDA approved devices or pharmaceuticals, there's been lots of morbidity and mortality related to things that have been approved. So to me, like, I, as a physician, have to research all of it and come up with what I think is best for the patients that give them the best options. I can provide, multiple solutions, but look at the safety of it too.
Yep.
And that goes back to guidelines and who's writing them, and, why are we against, compounding pharmacies? And yeah, I think I clearly found it just after a weekend deep dive. But
Oh, yeah.
yeah. But anyhow, so I think that anything else that you're talking about? So we talked about peptides, delayed, and delayed is probably a big one with our viewers. So if we need to get back on and talk at some point, I'd love to see what the viewers have questions on. I know delayed ejaculation was one of them that they had recently been inquiring about. Anything big in men's health, sexual health, otherwise that you think we can quickly, just address, and then maybe schedule another?
I do these talks all the time, and even when I'm teaching at universities, I just did a integrative medicine conference, but talking about the progression from the commercial products, like again PDE5 tablets.
Mm-hmm.
We can go deep dive and talk about the difference between the availability, the side effects, the issues with the oral tablet versus the sublingual compounded versions in terms of rates of absorption, bioavailability, the capacity to incorporate multiple active ingredients. Again, things like compounds for premature ejaculation, for delayed orgasm, for Peyronie's disease, optional treatments for testosterone replacement therapy instead of pellets or injectables, using some of the SERMs like the enclomiphene, HCG, and then, what types of testosterone do you want to use? And for men and women. So, we're now really getting into the functionality in terms of the compounding. The next thing that we're bringing to market is the testosterone and MCT, which compared to the commercial product, if you've ever used a commercial product and tried and draw it up in a syringe, it's thick, it's heavy, it's uncomfortable to inject. You have to use a big needle. The seed oils like grapeseed oil or sesame seed oil are much thinner, but there's still some reactivity with those in terms of allergen response. MCT is thinnest of all of them and the least reactive. So this is now kind of what everybody is looking for, and it's coming out here in the next 2 weeks. We'll have that out on market, and in concentrations for both men and women.
Okay.
And then the same type of a thing as far as, topical testosterone. The compounded versions of the topical testosterones are so much different than the commercial products. And, even things, we talk about, men aromatizing and you have to put them on aromatase inhibitors. Well, we forget about the
Mhm.
natural approaches. We forget about supplements. We forget about, I think probably the least talked about hormone for men is progesterone. But progesterone has activity in terms of anti-aromatase as well as 5-alpha reductase. So if you incorporate low dose progesterone in with a man's testosterone therapy, you block the formation of DHT and you inhibit aromatization into estrogen. So there's so many ways that we can really, really advance the therapy and
Mhm.
again, design things that give patients much better outcomes in a much more natural way.
Good. Well, then we'll have to definitely plan and get back on and talk about some of these because even in clomiphene, we've had a podcast on in the past.
Yep.
And I know that we've had further questions about that. That would be an awesome one to touch
Clomiphene is my favorite these days. I love it.
on. Enclomiphene is?
Yeah.
So tell me why you like enclomiphene better.
So clomiphene or clomid has two isomers. It has zooclomiphene, which makes up 32% of that drug. Zooclomiphene has a 30-day half-life. Enclomiphene makes up 2/3 of that. Enclomiphene has a 10-hour half-life. So all of the negative effects, issues with even things like gynecomastia, different issues can really stem from the zooclomiphene. Visual
Okay.
disturbances, much higher rate, whereas enclomiphene is the clean isomer. So much easier and better for the guys to use.
Okay. All right. I love it. Well, that'll be a quick, short answer for them. I've
There
been
you go.
asking about that for sure. So, well, awesome. Well, it was wonderful to have you on,
Thank
and
you.
we could talk forever, but we will definitely plan another one and we'll talk about some of those others. I'd love to hear about the testosterone and even deep dive into the enclomiphene, your other combination products that are
Yep.
great for men. So absolutely. But thank you for taking time out of your day and having this discussion with me. It was super helpful. And we will be in touch for sure. I want to look at your compounding pharmacy and everything that you're doing. And then we will plan another podcast. Okay, Greg?
Sounds good. I appreciate it.
All right. Thank you so much, Greg. Have a
Thank
great
you.
day.
Bye bye.